Welcome to AETCM, the emergency medicine channel. Shall we start, ma'am? A 28-year-old female came to ER with complaints of acute onset abdominal pain since 1 hour. On initial 10-second assessment, airway was patent, no pooling of secretions. Breathing SpO2 was 98% on room air. Respiratory rate was 18 breaths per minute. Circulation heart rate was 100 beats per minute. NBP was 140/80. Disability-wise, GCS was E4, V5, M6. Exposure, afebrile. Pain score was calculated to be 8/10 and patient was initiated on analgesics. Coming to adjuvants,
what analgesic?
Initially PCM was started. Coming to adjuvants, we took an ABG and CBC CRP. ABG showed pH of 7.425, potassium of 3.5, sodium of 137 and lactate of 2.6. There was no acidosis or alkalosis. Coming to CBC CRP, total
lactate was elevated.
Mildly elevated, 2.6. Total count 6.92, HB was 12.2, platelet to 205, CRP 0.2. Coming to sample history, a 28-year-old primary gravida female, a period of gestation of 7 weeks 4 days, presented with acute onset abdominal pain. She was APT positive on 29/25 and beta HCG was 822 on 29/25. Pain was sudden in onset, localized to lower abdomen and have increased in severity over time. There was no history of trauma, vomiting, no dysuria or burning micturition or bowel disturbances, no passage of products of conception or heavy bleeding per vagina, no syncopal episodes or short-lived pain at presentation. The patient has a married life of 2 years and had undergone infertility treatment with 5 cycles of ovulation induction with letrozole but failed, and also had underwent diagnostic hysteroscopy plus chromatubation to check the patency of the tubes 2 months back, which showed bilateral tubes were patent. There was no history of previous.
This was done when was this done?
2 months back, ma'am. No history of previous ectopic pregnancy, pelvic inflammatory disease or tubal signs. All this pelvic inflammatory disease and tubal surgeries can cause tubal scarring and adhesions which can lead to ectopic pregnancy. No history of intrauterine devices. Certain intrauterine devices release progesterone and can cause reduce the ciliary motility and can cause ectopic. No history of previous abdominal or pelvic surgery. No history of smoking or alcohol history. The smoking also can cause loss of ciliary actions which can cause ectopic.
So here we have a primary gravida, already UPT was already positive, beta HCG was also elevated. So she is known pregnant with a period of gestation?
7 weeks.
7 weeks. So she is in first trimester. She has come with severe abdominal pain. Only pain?
Yes.
No bleeding? No other
pain.
Okay. So what are the differentials in a patient who is primary gravida presenting with sudden onset severe pain?
First, differential diagnosis ectopic pregnancy. Second one is incomplete abortion also can.
Miscarriage can be there. So, but mostly it can all present, but in many of the conditions it presents with vaginal bleeding, no? So in this case, the patient does not have any vaginal bleeding, only acute onset abdominal pain. So you have to think of other diagnoses also, other differential diagnoses other than the obstetric parts. We will stick on to obstetric part only. So it is mostly in first trimester. If a patient comes with this complaint, it can be either ectopic or miscarriage. Okay, so how do you differentiate what is what? Miscarriages are of different types, no? So you rule out that in history. You said patient did not pass any product of conceptance was not passed. That suggests patient is not in what type of miscarriage?
Complete.
No, incomplete miscarriage. In incomplete miscarriage and inevitable abortion. In inevitable abortion, the patient has already passed the conceptus and the cervical os will be dilated. Same is the case with incomplete abortion. So now sticking on to ectopic, most likely diagnosis of ectopic pregnancy. So what are the factors in this patient that can give you hints that the patient is likely to undergo an ectopic pregnancy?
Patient having
history of infertility. A patient has already received there is chromotubation and other techniques that have been done, no? So these and all are risk factors. What is the age of the patient?
29 years old.
So what is the maternal age which increases the likelihood of ectopic? More than 35. Why? Because the motility, the ovum, the egg release, everything will be delayed when a patient has a maternal age of more than 35. Cigarette smoking, factors like that. Any case of previous assisted reproductive technologies, or patient had the highest risk factor is previous history of ectopic pregnancy can cause further ectopic pregnancy. The chance of recurrence rate is high. And other procedures, any other procedures which have been done in the fallopian tube, or the patient had TB which has affected the ciliary motility, etc., can lead to ectopic pregnancy. So these are the risk factors. And the patient also had procedures done. She had history of infertility also. So we can go on more. This all relates to more to ectopic pregnancy. So if a patient present with an ectopic pregnancy, what are the usual signs and symptoms that can be seen in the patient?
Patient, if we are suspecting a ruptured ectopic, then
normal ectopic pregnancy unruptured, what will be the signs? Mostly patient will have amenorrhea for this many duration.
More than 12 weeks of
more than 12 weeks of amenorrhea. Patient will have vaginal bleeding, abdominal pain will be there. On examination, you might find bradycardia. Why? Due to vagal stimulation, there can be bradycardia. Patient can have cervical motion tenderness. There can be adnexal mass and adnexal tenderness. And if the patient has a ruptured ectopic, what are the signs that patient will present to you with?
Due to, if we are suspecting, then patient can have a shoulder tip pain because of peritoneal irritation.
Diaphragmatic irritation. It will radiate to the shoulder tip.
And also peritoneal irritation can cause abdominal
guarding rigidity. So peritoneal signs you can get. Patient can be in shock.
Also lead to shock.
Yeah. So these are the features that suggest that patient has a ruptured ectopic pregnancy. Okay. So we have gone through the risk factors and the presenting signs and symptoms. Now, what will you do? What are the investigations to be done? If this, we know that the patient is pregnant and all. So, what if a patient in a reproductive age group presented to you with this complaint with a history of amenorrhea for so and so period duration? What are the investigations that has to be done to that can suggest to you of ectopic pregnancy?
Initially, we'll have to get a UPT
done.
To show that patient.
Okay, so if UPT is positive, then
beta HCG level.
Serum beta HCG, that is the quantitative beta HCG has to be done. The UPT is qualitative beta HCG test. When is beta HCG positive in urine? And when is beta HCG positive in serum?
In serum, once the placenta starts producing,
it is once it starts, that is a progesterone serum progesterone level starts increasing after 10 weeks because in the initial 8 to 10 progesterone level is there in the body initial 8 to 10 weeks it is mainly by the ovaries. The placenta starts producing progesterone after 10 weeks. So what should be the level of progesterone which is ideal? We say that more than 25.
If less than 5, then we are strongly
suspective of pathological pregnancy. If less than 10, it is more likely to be a pathological. More than 25 is safe of intrauterine pregnancy. So when the UPT is positive, you have to confirm it with a serum beta HCG. And even if the UPT is negative, but you have a strong suspicion of ectopic, then also you have to go for a serum beta HCG. Okay, so serum beta HCG level has to be checked. And what else have to be checked in serum beta HCG? What is doubling? What is the doubling time?
24 to 48 hours.
1.8 to 3 days. No, not 24 to 48. It is 48 to 72 hours. You have to check. So what do you see after checking after 48 hours?
Normal intrauterine pregnancy, then doubling will be seen.
It is 53% increase in beta HCG has to be there, suggestive of a viable intrauterine pregnancy. So that is beta HCG.
And the rise and doubling time will increase in any pathological pregnancy.
Any pathological pregnancy. Also, it is not significant. Not mandatory that this can lead. I mean, if it does not double, that is not a normal pregnancy. Nothing like that. Then coming to ultrasound scan. Scan is another thing. What are the two types of scans that we do?
Transabdominal and transvaginal.
What is the difference between the two?
Transabdominal.
Transvaginal scan has more frequency, and it is of depth is also less depth, high resolution, high frequency, and
but more invasive.
Trans-abdominal is opposite to that, less invasive. Always a trans-vaginal scan is preferred. It can pick up intrauterine gestation 1 week earlier than trans-abdominal. When do you see the feature, gestational sac and yolk sac and all, at what weeks can you see it in an ultrasound?
4.5 weeks in transvaginal and 5.5
What in 4.5 weeks?
Intrauterine sac in
gestational sac at 4.5 weeks
and yolk sac in 5.5 weeks in transvaginal.
And your fetal pole you can see at 6 weeks. This is a normal duration at which you see it in an ultrasound scan. Okay. Now, what are the features in ultrasound that suggest to you of ectopic pregnancy? There are features suggestive of ectopic pregnancy, diagnostic of ectopic pregnancy. What are the features that are suggestive?
Ma'am, when we are doing the ultrasound, the primary goal is to confirm a viable intrauterine pregnancy and exclude ectopic pregnancy. But previously, the existence of intrauterine pregnancy would exclude ectopic. But nowadays, we have seen that this can coexist, both extrauterine and intrauterine.
Mostly in conditions where
IVF,
IUD, intrauterine devices have been inserted. Patients can have an heterotropic pregnancy, that is both intrauterine and ectopic pregnancy. By the way, what is ectopic pregnancy?
The presence of conceptors outside the uterine cavity is called.
Anywhere outside most commonly?
Ampullary of the fallopian
tube. And can be anywhere else other than the endometrium. And normally after ovulation, when does the implantation happen? No, 7 to 10 days after the ovulation, implantation in the endometrium happens. Okay, now can go forward.
So, once you have ruled out,
the ultrasound features.
If we have the diagnostic features in ultrasound is if we are finding an empty uterus with beta HCG positive, and if beta HCG is more than 15,000 to 2,000, then high suspicion. If there is an extra uterine gestational sac, then ectopic is confirmed. And if there is a tubal ring sign or adnexal mass which is not separated from the adnexa, then also we are suspecting an ectopic. Tubal ring sign 100% ectopic. Then other ancillary findings of USG is any free fluid in the pelvic, 52% risk of ectopic. Complex pelvis mass, 72% ectopic. Moderate or large fluid in the free fluid in the pouch of Douglas, 86%. Tubal ring sign is around 96%. Mass plus free fluid in the pouch of Douglas, 97%. Hepatorenal free fluid, 100%.
100%. That is the ultrasound findings of ectopic. Normally, if there is a pregnancy which get implanted in the fallopian tube, what are the course that can happen to that pregnancy? It can either spontaneous involution of pregnancy, or it can cause rupture of the tube, or it can go abortion into the peritoneal cavity. These three things can happen. So the features, if now coming after the ultrasound, there is something called a discriminatory zone. What is a discriminatory zone?
If the beta HCG levels are around more than 15,000 to 2,000 or more than 6,000, and you are not seeing intrauterine sac in transvaginal or transabdominal scan, then you are in a indiscriminate zone, and where you are not finding an intrauterine sac or ectopic pregnancy findings, all these findings, whatever I told, then we'll have to see the patient, observe the patient, admit the patient, and look for doubling of beta HCG post 48 to 72 hours. If it is doubling, then we can safely discharge the patient, or if it is not rising, doubling but rising in a plateau stage, then we'll have to suspect ectopic.
So it is that value of beta HCG where in that scan, when you have that value of beta HCG and you do a scan, you have to see the fetal pole and the cardiac activity. So that is in transabdominal, it is
More than
6,000.
6,000.
And transvaginal it is
More than
1,500. At least this level of beta HCG, if it is there, and if you don't find the intrauterine pregnancy in ultrasound scan, it is more likely that the patient has gone into ectopic pregnancy. That is a discriminatory zone. Are there any other tests to be done in a patient? We talked about serum beta HCG, serum progesterone, and ultrasound. What are the other things that can be done?
MRI also can be done.
Yeah,
but,
it has very high sensitivity,
but time consuming and money consuming.
Okay, and are any other serum markers?
Laparoscopy is both diagnostic and therapeutic.
Any other serum markers? Pregnancy associated proteins, serum estradiol, serum endometrial proteins, these and all are serum markers of pregnancy. Okay, now coming to management of ectopic pregnancy, how do you manage the patient?
Treatment mainly it's either surgical or medical. Medical is done when the patient is hemodynamically stable, unruptured tubal pregnancy, beta HCG less than 5,000, no fetal cardiac activity. Drug of choice is methotrexate, and there is no
What is methotrexate?
contraindication. It's a folic acid antagonist which inhibits dihydrofolate reductase, so that prevent synthesis of DNA and RNA and causes trophoblastic cell death. So there is no growth.
So how should it be given?
It can be given in 2 regimens. It can be either single dose or multi-dose regimen. In single dose, we'll give
Which is preferred? Single dose regimen is more preferred. Okay. How much has to be given?
50 mg per meter square.
Microgram.
Check, and then after giving, you have to check the beta HCG on day 4 and 7. If not decreased by more than 50%, then repeat the dose.
Okay, what are the if a patient present to you, you gave a methotrexate, a single dose you have given. If the patient has is complaining of abdominal pain, what to do? What can be the cause?
Again, the rupture of that.
It can be rupture, or second it can be hematoma formation leading to tube dilation.
Or it can be abortion
also. So you can give NSAID for the management of pain. Other side effect of methotrexate is flatulence and stomatitis, etc. Methotrexate, what are the contraindications in conditions where you don't give methotrexate?
Methotrexate has both absolute and relative contraindications.
Main contraindication I'm asking, if the patient is hemodynamically unstable, fetal cardiac activity is present, patient has a
HCG more than 5,000.
More than 5,000.
Patient is having immunodeficiency, severe anemia, or patient already having bone marrow suppression.
Intrauterine pregnancy, you don't give methotrexate. Relative contraindications?
It can be inability to follow up, ectopic size more than 4 centimeter, or if you are seeing an patient beta HCG more than 5,000 is also relative.
Relative contraindication. Okay, what is expectant management? Okay, we'll talk about surgical management next. After medical management, what are the surgical management? And when to do a surgical management?
Surgical management is indicated when the patient is hemodynamically unstable, if there is signs of rupture, contraindication to methotrexate, or failed medical management. Either we can go ahead with a laparoscopic salpingotomy or then salpingectomy or laparotomy in severe hemodynamic instability case.
What is expectant management? Expectant management is a scenario where patient is less than 6 weeks, does not have much pain, does not very minimal bleeding. In those patients who is hemodynamically stable, we do expectant management. Means we'll check the beta HCG, we'll ask the patient to go and come back if she develops severe bleeding and severe pain, and you repeat the UPT after 7 to 10 weeks. You ask them to repeat the UPT. This is the expectant management. So this is the basic treatment and clinical. We have already talked about the signs and symptoms, how a patient presents, what are the investigations to be done, and what is the management. That is medical management and surgical management. So if a patient presents to you with ectopic pregnancy and the urine pregnancy test is positive, what to do? You'll have to do a quantitative serum beta HCG. Along with that, you have to do a pelvic ultrasound has to be done. So if the pelvic ultrasound shows intrauterine pregnancy, what is the next step? you have to look for features of heterotropic pregnancy. If a patient is known is on intrauterine devices and all, then you have to give an urgent OBG consultation because there are chances of heterotropic pregnancy. If a patient has ectopic pregnancy, then you can move forward with the algorithm that we talked about. But if you are in doubt, then what to do? Again you have to give an OBG consultation. But if the UPT is negative and but you have a very strong suggestive features of ectopic pregnancy, then you'll have to go forward with serum beta HCG. And after serum beta HCG, if it is negative, then
again ultrasound has to be.
No, if it is negative, then it is serum beta HCG is negative, then you can send the patient and ask them to follow. But if serum beta HCG is positive, and then you have to do a pelvic ultrasound and accordingly you'll have to manage. Okay.